siendo la primera endovascular.
Good afternoon, and thank you all for joining us in our broadcast. Today, we have Dr. Ajit Thomas. Unfortunately, because of last-minute circumstances, he will not be able to give his lecture in person, but we do have a pre-recorded backup that we are going to be able to present. So Dr. Thomas is the Director of Endovascular and Operative Neurovascular Surgery at Beth Israel Deaconess Medical Center and Associate Professor of Neurosurgery at Harvard Medical School. Today, we're going to be seeing his lecture about middle meningeal artery embolization for chronic subdural hematoma. Since he will not be available today to answer his questions in person, please write your questions and your email, and we will be able to send you the answers via this way late afterwards. Thank you. So now we continue with Dr. Thomas's talk, treatment of chronic subdural hematomas with embolization of the middle meningeal artery.
It's a great pleasure to be here today to talk to you about the treatment of chronic subdural hematomas with embolization of the middle meningeal artery. I want to thank the fellows and residents who helped with this, Mir, Dominic, and Alejandro. So I just want to define what a chronic subdural hematoma is. It's basically an encapsulated collection of fluid, blood, and blood degradation products, which are laid between the arachnoid and the dura mater. So this is the arachnoid here, and this is the dura, and this is where the subdural collection is. And usually it looks chronic, but there can be an acute component also. As you see, these white areas denote blood. And it is a fairly significant problem, especially among the elderly. There are at least 17 to 20 cases per 100,000 people per year, and it is more than double the rate of aneurysmal subarachnoid hemorrhage. By 2030,
Hello, we're having some technical difficulties. Please stay with us for a few moments as we fix the audio issue. Thank you.
and this is where the subdural collection is. And usually it looks chronic, but there can be an acute component also. As you see, these white areas denote blood. And it is a fairly significant problem, especially among the elderly. There are at least 17 to 20 cases per 100,000 people per year, and it is more than double the rate of aneurysmal subarachnoid hemorrhage. By 2030, in the United States, we expect to see about 60,000 new cases of subdural hematoma. and it's very common in the elderly with medical comorbidities. The known focal signs make the diagnosis challenging, but it's a little easier with the easy availability of scans. It's also a significant etiology for reversible dementia. There are very few etiologies for dementia that's reversible, and chronic subdural hematoma is one of them. It is a fairly morbid diagnosis because of a couple of reasons. One is a lot of patients these days are on antithrombotic medications and antiplatelet therapy, and surgery on chronic subdural hematomas when you're on these agents are associated with a risk of recurrence, which is quite high. It is also a sentinel health event. And if you look at large databases like the Medicare database, you find that the 6-month and 1-year mortality can be as high as 20%, and in some papers as high as 30%. It's a sentinel event, like a hip fracture. When you have a hip fracture, the cascade of events that follow result in morbidity and mortality. So what has changed about our understanding of chronic subdural hematomas? The one big thing that has changed is the origin of these hematomas. Previously, we thought that you have some form of a trauma to the brain and a bridging vein ruptures, and you have this chronic insidious bleed that develops over days to weeks. But now we know that's not true because we have scans on these patients, a few days after the hemorrhage, after the trauma. There's no subdural hematoma or venous bleed there. And the current generation of CT scanners are good enough to pick up even small areas of hemorrhage. So what is the etiology? And the etiology has to do with what you call the border cell layer of the dura. If you look at the dura, what you see is that the dura has several layers: the periosteal dura, the meningeal dura, and then you have this border cell layer, which is adjacent to the arachnoid space and the subarachnoid space. And what happens is there is disruption of these border cells, and there's hemorrhage and inflammation. So what you see here is you have traumatic head injury, the border cell layer is split open, you have inflammatory cells coming in there, attempting to repair it, forming membranes. And these membranes then have angiogenic factors which promote formation of new capillaries. These capillaries tend to be very fragile, and they can rupture and again cause hemorrhage. And this cycle continuously reinforces itself and eventually results in the development of a large chronic subdural hematoma. If you look at the actual angiograms of these patients, one of the findings you find is that the middle meningeal artery is dilated, and there are these large cottonwool-like capillary vessels that originate from these the main branches. You also find that the dura itself has multiple areas of new blood vessel formations on pathology. So if you look at all the causes, and then you go on to treatment, the conventional treatment with medication addresses some of these pathology, especially the inflammation and angiogenesis. The ACE inhibitors and statins, for example, decrease the inflammation and angiogenesis. Decadron or dexamethasone decreases inflammation, and tranexamic acid prevents the bleeding of the fragile capillaries. When you go on to surgical treatments, you're dealing with the growing hematoma that's producing the symptom, and you're just evacuating the hematoma, but you're not addressing this, the main pathophysiology. And what you realize is there's a balance between these two. So though you don't address this, very often removing enough hematoma tilts the balance that these become quiescent and the chronic subdural hematoma eventually resolves. And surgery, as you know, could be done either as a small borehole, twist drill, or you could do a small craniotomy. And it's very usual to place a drain after you do these procedures. The issue with conventional treatment is the high rate of recurrence. And this is because of the chronic inflammation and angiogenesis that you don't address. Drains have been suggested as a remedy for this, but even with drains, the reoperation rates can be fairly high. So we have looked at our own series here at Beth Israel. Out of 325 patients that we treated surgically, the total reoperation rate was about 13%. So if you look at the repeat operations, you can see that of the patients we did, most of them, 224, had with unilateral and 57 with bilateral, we just required one surgery and they resolved. But at least 32 patients required a reoperation, 6 required 2 reoperations, and you can see some of them required as many as 3 or 4 surgeries. And what are the factors associated with recurrence? At least in our study, what we found was the presence of loculation, use of antiplatelet or anticoagulant therapy, and then the percentage of hematoma change after surgery. So the x-axis denotes the hematoma thickness change after surgery. So if you were to remove most of the hematoma, then the reoperation rates are very close to 0. But if there's a lot of clot, if there's significant amount of hematoma left after surgery, the reoperation rate goes up significantly. Now, the medical management, there have been several trials, especially with steroids. This is a trial which randomized to steroid and surgery, or just surgery, and they did not find any significant change in the recurrence rate or the clinical outcome. This was a larger trial done recently in the New England Journal of Medicine, which is reported in the New England Journal of Medicine, where 748 patients were randomized to dexamethasone plus surgery or placebo and surgery. And actually, a favorable outcome was reported in 83% of the dexamethasone group and 90% of the placebo group. In other words, there was no big difference. And similarly, there may have been some decrease in recurrence with the dexamethasone group, but eventually there was no significant change in the outcomes. Similarly, the use of tranexamic acid has been studied, and again, you don't find much of a difference between using them and not using it. So this is, again, patients randomized to the tranexamic group, and you can see that the hematoma volume was slightly smaller in the tranexamic group than the other 2 groups. This is a ACE inhibitor, perindropyl, which was tried along with boreholes. So you have 2 groups here, perindropyl and with borehole, or placebo and borehole. And it did not diminish the size of residual chronic subdural hematomas 6 weeks after borehole surgery, and it did not decrease the risk of chronic subdural hematoma recurrence. So we now come to the rationale behind using middle meningeal artery embolization as a novel approach. And the main rationale is that you devascularize the dura so that you can take down this process, the inflammatory process and the angiogenic process, by making the dura ischemic. And the basis of this is when you look at CT scans, this is a contrast enhanced, this is a dynamic contrast CT. So you do the CT a few minutes after you inject the contrast, and you can see how the dura lights up in chronic subdural hematoma. You can see that they have graded it into 3 grades, and you can see in the 2nd grade the meninges enhance here. And again, here, this is a chronic subdural hematoma, and you can see the enhancement of the membrane. So the membranes are very vascular here. So we then come to MRI scans of these patients. And this is a study which compared the middle meningeal artery on the hematoma side and the non-hematoma side. So if you look at this patient, the chronic subdural hematoma is on the left side, and this is the MRA. And what you see is that the middle meningeal artery is really enlarged on this side, while on the right side, which is the normal side, it's much smaller. And if you graphically plot it, you'll find that this is the diameter of the middle meningeal artery. This is the non-hematoma side, and this is the hematoma side. And you can see that on the hematoma side, the middle meningeal artery is much larger. So what is the indication for embolizing those vessels? Usually, if they're a high-risk surgical candidate with multiple medical comorbidities, if the patient is on dual antiplatelet therapy and anticoagulant therapy, and you want to resume it early, or if surgery is difficult because of the presence of these agents. For recurrent or residual subdural hematomas after surgery. And the contraindications are obviously if you have a significant neurological deficit, you want to go straight to surgery, or significant mass effect. Now, this is how we started out 2-3 years ago, but as time has gone on, we have become more aggressive, and sometimes we have treated patients even with significant mass effect as long as they don't have a neurologic deficit. And many patients have been treated upfront with middle meningeal artery embolization, even if they were not on DAPT and anticoagulant therapy, or if they didn't meet these high-risk criteria. This is from Barrow, showing some of Barrow Neurological Institute from one of their papers, which show some of their criteria. If they're asymptomatic small, they are medically managed. Asymptomatic with greater than 8 millimeter in size, plus minus midline shift, MMA embolization. If greater than 5 millimeter midline shift or a large chronic subdural hematoma, they go to surgery and MMA embolization. And this is a reasonable approach, but sometimes even when there is more than 5 millimeter midline shift, if their neurological deficit is minimal, then in our experience, we have found that MMA embolization is still a reasonable option. So let's go on to the first report of the middle meningeal artery embolization. This actually happened 21 years ago. It's a Japanese paper, and they reported a 59-year-old male who presented with coagulopathy due to liver cirrhosis. He had a couple of borehole surgeries, and he was still having recurrence. So they placed an Ommaya reservoir, and they removed the hematoma to the reservoir once weekly to maintain the patient's neurological condition. Eventually, they did an angiogram to embolize the middle meningeal artery. And what they found was this Cottonwool. This is the early arterial phase, the late arterial phase, and the capillary phase. And you can see how the membranes seem very rich in its vascular supply. All these black areas denote the rich blood supply. And so they embolized it. This is the middle meningeal artery. And after the embolization, you can see it's missing here. And 7 months later, the patient's chronic subdural hematoma had completely resolved. And then there was a hiatus. And then in 2013, again, from the Japanese, they reported 5 patients who've had multiple surgeries. They used NBCA, which is glue, and 1 patient with PVA to occlude the middle meningeal artery, and none of them had a recurrence. This was followed by another series, again with 21 patients, and of all the 21 patients, and none of them had a recurrence after the procedure. The first US experience was reported from Cornell in 2017, where they did it as standalone treatment without surgery, 5 patients, no recurrence, and they had symptomatic relief. Then we had this very interesting paper from South Korea, which compared patients in embolization and conventional treatment groups. So you can see in the subdural in the conventional group, you had 67 patients were being observed, 394 had borehole drainage, and 8 patients had craniotomy. Similarly, these were the numbers in the middle meningeal artery embolization group, 43 patients with borehole. So looks like patients who had borehole or observation predominantly got a MMA embolization. And what you can see is in the embolization arm, the number of patients who required a surgical intervention was 1 out of 72, or 1.4%. And look at the conventional group. The surgical reoperation rate was close to 20%. And the treatment complication was higher, 4.3%, versus 0 in the middle meningeal artery embolization. It seems difficult to believe these numbers, but what has happened subsequently is many people have reported large series, and they all seem to correspond to these numbers. The Cornell experience, again, shows that this was again in 2018, where they reported on a larger number of patients. So these are 42 patients with chronic subdural hematomas in 32 patients, some of them bilateral, and these patients received MMA embolization up front. Then there were some patients who received MMA embolization in the perioperative period, 10 patients, as part of surgical drainage, and 8 chronic subdural hematomas received MMA embolization for recurrence of the subdural hematoma. And you can see that their reoperation rate, which was the primary endpoint, requiring surgery, was 8.9%. So the majority of patients were able to avoid surgery in this group. And the procedure-related complications, again, were 0%. So if you really look at all the different treatments, surgery is able to reduce the mass immediately, and the success rate is very high, but there is also a recurrence associated with it. Medications alone, success rate is low. If you look at Decadron, they tend to address inflammation and angiogenesis, but the endovascular devascularization addresses the pathogenesis and has a very high recurrence rate. The only contraindication seems to be a large chronic subdural hematomas or patients who have significant neurological deficits. So what are the advantages? The advantage is that you're treating the underlying cause, reducing the risk of recurrence. It's minimally invasive. You can do it with sedation or for anesthesia, and you can continue antiplatelet and anticoagulant treatment if you need to. It's not done routinely, but we have done it on several occasions. And essentially what you do is, if this is the middle meningeal artery, you basically embolize it and take it down completely. And this is the internal carotid artery here. You can see the middle meningeal artery where it was. This patient obviously had a borehole drainage, and after that, the middle meningeal artery was embolized. So what are the major considerations in patient selection? One is you want to make sure there are no dangerous anastomoses. And if you have patients who have significant symptoms, then you want to do it. For asymptomatic patients, we generally don't recommend it. We can monitor it and watch it unless there is a fairly large, significant size. So I wanted to go over some technical nuances here. The anatomy of the middle meningeal artery can be variable. There's potential for complications if not correctly interpreted. And so you want to do an angiography of the MMA to assess the anatomy. You also want to do an internal carotid artery injection to demonstrate the origin of the ophthalmic artery. It's very important because if the ophthalmic artery is arising from the middle meningeal artery, then it's harder to embolize. And I'll show you some cases. Particles. So what are the agents you use for embolization? You can use particles, which is PVA or embospheres. You can use liquid embolics, onyx, NBCA, or squid. And sometimes we actually take down the main trunk of the vessel or some of the branches with coils. So this is the most common configuration of the middle meningeal artery. You have a common trunk, and the trunk divides into the frontoparietal branch here and the squamosal or temporal branch here. And what we do is we get into each of these branches, at least in our institution, and we use particles to embolize. And finally, we take down the parent vessel with a coil. Now, if you look at this carefully, you can see that there is a branch going to the lacrimal gland, and that's where you have to be careful. Because in this patient, you would want to get your catheter distal if you're going to use particles. And you have to be careful that they don't reflex back here. Now, this is an unusual branch here. This is called a petrosal branch. See, this is a third branch. And if you're going to embolize with this, you want to be beyond this because the petrosal branch sometimes can supply the vasonervorum of the cranial nerve 7 in the skull base. So you can get a facial nerve palsy if you inadvertently embolize it. And I was talking to you about the ophthalmic artery. So this is a middle meningeal artery here, and you can see how it has a connection to the lacrimal artery here. But eventually it seems to anastomose with the ophthalmic artery itself. And that's an important thing to remember because as you embolize, if you see this connection, you want to be fairly distal if you're going to do any embolization. And then you want to carefully watch for reflux. The other option here is if you're sure the ophthalmic artery is originating from the internal carotid artery, you could just leave a coil here. So that way you take it down with coils rather than using particulate embolization. This is again another image showing the connection to the ophthalmic artery. So this is the main trunk. This is the frontoparietal branch. And you can see how this goes in anastomose to the ophthalmic artery. So here again, the option is you have to get fairly distal here and embolize and make sure that you don't come back, or you get into this vessel here and you can just leave a coil mass here. Now, this is what I was telling you about the ophthalmic artery not originating from the internal carotid artery. So if you look at this patient, you can see that you don't see an ophthalmic artery from the internal carotid. And then you see the middle meningeal artery is what gives rise to the ophthalmic artery. You can see the retinal blush from the middle meningeal artery. So this supply to the ophthalmic artery is exclusively from the middle meningeal. So this is one situation where you cannot put a coil and take it down. So this is a patient, if you want to treat, what you'd have to do is you have to get distal to where the ophthalmic artery origin is and see whether you can put a coil somewhere here. And using particulate embolize, this is where you'd have to leave the coil. I just want to show you some of the common anastomoses. This is the frontoparietal branch. And again, these are the branches that we mentioned to the meningolacrimal artery, the medial sphenoidal artery, and anastomosis with the ophthalmic artery here. This is a branch which is anastomosing here. You can see with the petrous branch of the middle meningeal artery. And this is where you can get, as I said, if you inject particles, it can go to the seventh nerve and cause facial nerve palsies. This is a cavernous carotid branch that it's anastomosing with. So this is the middle meningeal artery, and you can see how there is collaterals that connect to the cavernous carotid. And this is the parieto-occipital branch, which connects to the posterior meningeal branch, which goes down into the vertebral artery. And lastly, this is the petrosquamous branch of the middle meningeal artery, which can again anastomose with branches at the skull base. So there is some risk of cranial nerve palsies when you do these, or embolization into the PL vessels. But overall, if you're careful and you look at the anatomy carefully, you can reduce this risk substantially. And these are the patients who actually benefit the most. You can see how these patients have rich supply of their membranes, and you can see this cotton wool appearance. You don't see it in all the patients, but when you see it, usually the effect is pretty dramatic. So what does that cotton wool appearance denote? It denotes that there is neovascularization by distal small middle meningeal artery branch vessels. And the contrast pooling suggests that the membranes are leaky and the immaturity of these neovessels. So as I said, we can use different ways of, we have different ways of embolizing it. But eventually, as this paper from Barrow showed, there was no difference in outcomes of the different utilized agents. And even our experience has been the same in a series that we have analyzed, and I'll show it to you in a little while. So what is the advantage of using a liquid embolic agent? The advantage is that you could go deeper. There's deeper penetration and preventing collateral vessel formation. It is permanent and avoids recanalization, which can occur with particles. It enhances visibility of the embolic agent during procedures. Disadvantage is that it can penetrate smaller vessels. There is a higher risk of complications if there is a dangerous anastomosis. The injection is painful, so we often require general anesthesia. And in some situations, it may be considered expensive compared to particles like PVA or embospheres. We ourselves have not used liquid embolic agents because we haven't found any significant advantage compared to particles. So this is an example of a patient who was treated with NBCA embolization. So you can see this is the middle meningeal artery. Middle meningeal artery. This was a patient treated by Dr. Ajit Puri at UMass. And you can see this is the NBCA cast after the treatment. And what you find is that the NBCA migrates all the way down even into the falcine branches. This is the AP view, and this is the lateral view. Similarly, this is a patient we had used onyx, and you can see how the onyx cast goes all the way up. It goes all the way into the sagittal sinus, and you can see there's some reflux into a scalp vein here. The other side, you can see we just used coils. Maybe we did use particles, and we took down the main vessel with coils. So now going on to some case illustrations. So this is a 74-year-old female who presented with weakness of the right side and memory disturbance. She was on aspirin, and you can see the chronic subdural hematoma here. We then found the middle meningeal artery on the left side, and we put the microcatheter, which is an SL10 microcatheter, over here, and then we embolized it with embospheres, which are particles measuring about 100 to 300 micrometers. And this was the area that was embolized. And finally, we took it down with coils. So you can see that we hadn't embolized the branch here, the squamous temporal branch, but you can see that this patient eventually completely resolved. This is the chronic subdural hematoma 1 week after embolization, and this is about 2 months after. So I've always felt with chronic subdural hematomas, you don't have to treat it 100%. As long as you can tilt the balance to that it favors resorption, then you have won the battle. This is a patient who had reaccumulation after craniotomy. So this is an 88-year-old male who fell from a bike. He was on aspirin. This is his post-op image, and it looked pretty good. But then he comes back 2 months later, and you can see he has recurrent hemorrhage in this area. So we eventually treated it, and then we had MMA embolization, and this is his 6-month follow-up. And you can see that the subdural hematoma is completely resolved. This is a patient who had a borehole surgery, and he had presented with to the ED with headaches following a head injury. He fell off the bed, and his this is a chronic subdural hematoma on the left side, and you can see how there is a large amount of air here, and following this, he comes back 6 weeks later, again with a big chronic collection on the left side. So at this point, we embolized it, and this is his final CT scan. So this was treated predominantly just with embolization. He had a mild right upper and lower extremity weakness, not significant. This is an 80-year-old patient who presented with gait disturbance. There is a coronary stent, and she was on aspirin and clopidogrel, and we wanted to continue it. So we embolized both sides. This is 3 weeks after embolization, and this is 3 months after embolization. It's very common that even when the embolization is successful, you could find a small membranous layer as it goes away. This is a patient who presented with Coumadin, and you can see how there is bilateral large collections. The INR was 5, we reversed it, and we just treated this with just embolization alone. And this is our scan at 4 months. So what is the recurrence rate with just EMMA embolization versus subdural drainage? It looks like the middle meningeal artery, the recurrence rate is only about 3.5% to 4% on an average. Whereas in the surgery group, it's closer to 20%. This is based on a large number of cases. You can see it's a meta-analysis, 200 cases of middle meningeal artery embolization and 688 surgery cases. This is a patient who had presented with middle meningeal artery embolization. There's about 154 patients. And what we found was that these were 15 centers. Our primary clinical endpoint was the proportion of patients requiring additional surgical treatment within 90 days after middle meningeal artery embolization, and proportion with greater than 50% subdural hematoma thickness reduction on follow-up CT scan within 90 days. We had a total of 138 patients, 154 embolization, 15 bilateral. You can see that 1/3 were women, 66% had just standalone treatment. A large percentage of patients, 30% were on antiplatelet treatment, and 23% were on anticoagulants. The median admission thickness of the subdural hematoma was 14 millimeters. About half the patients had treatment under general anesthesia, the rest were with sedation, and almost all the patients had successful procedures. 70% of the patients received particles, and 25% had liquid embolics. And what we found was there was only 6% of patients who went on to require additional surgery after we performed MMA embolization. And there was a 71% median reduction in the subdural hematoma thickness at 90 days. So from 14.6 millimeters, we were able to go down to 4.2 millimeters in a period of 90 days. And there was no difference between the different embolization materials, whether it was particles or liquid embolic agents. And this is a paper from Barrow. Because we don't have any randomized trials, the propensity adjusted comparison seems to be a reasonable way of looking at it. So they said patients who were treated with embolization, patients who were treated conservatively, and patients who had surgical evacuation. And you can see that patients who had surgery and conservative therapy had a high odds of treatment failure and incomplete resolution. And the middle meningeal was a much better option. And what about elderly patients? So in our series, we looked at elderly patients. We had elderly was denoted as greater than 65, and we have advanced elderly greater than 80 years. So you can see that in 46% of the elderly and 46% in the elderly and 61% in the advanced elderly were just treated with MMA embolization. And you can see the outcomes. 95% of the elderly and 92.2% of the advanced elderly were able to avoid surgery after MMA embolization. So the question of can it be done safely in elderly patients, at least our data seems to suggest that it can be done safely and is a reasonable approach. And what is a concern about doing it in elderly patients? The main concern is that you have to manipulate your catheters in an arch that is often atheromatous, and there is a risk of embolus going into the cranial vessels. Now, what about patients who have significant midline shift? So this is our series here from Beth Israel, and we had patients who had upfront, this is a group of 27 patients who had upfront middle meningeal artery embolization, of which at least half of them had a greater than 5 millimeter midline shift. And in most of them, 85%, we were able to avoid surgery. So, if they have a significant midline shift and a neurological deficit that's significant, they almost always go to surgery. And this is the important thing. The average time to resolution of the midline shift was 46 days in patients less than 5 millimeters and 51 days in those with 5 millimeters or more. So the midline shift does take some time to resolve. It's not immediate like surgery, but it doesn't, we never had a patient that deteriorated rapidly that ended up with a bad outcome because they didn't have surgery with this midline shift. So you have to be careful. If you have a midline shift and there is a significant deficit, they almost always go to surgery. But if you see a midline shift and the neurologic exam is very good, then there is an opportunity to do MMA embolization and monitor the patient. Now, we have looked at the evolution of chronic subdural hematomas with middle meningeal artery embolization. So several authors have tried to classify this. So this is the classification that we have used. This is what you call an acute on chronic bleed, where you have the acute bleed superimposed on this chronic bleed. And then you have homogeneous. So the homogeneous can be hypodense, it can be isodense, or it can be hyperintense, as you see here. You can have a laminar hemorrhage where you see this membranous laminar structure. This is what you call a separated or a gradation. So these are two components. There is this is more like plasma, and this is actually the more like packed RBCs. And normal head motion cannot homogenize this hematoma. So if you shake your head vigorously, it doesn't usually become homogeneous. And there can be two separate kinds. I'm not going to go into the details of that, but this is trabecular, where you have multiple trabeculae or membranes traversing the chronic subdural hematoma. So what happens after you embolize? You find that whatever it is, eventually it becomes homogeneous. And that seems to be the path that almost all of them follow, until once they become homogeneous, then they resolve. The density of the hematoma also decreases. So if you have a hyperdense hematoma, it becomes hypodense. And so these are some examples. So you can see this is what you call a gradation. And then a few days, about a month later, it became laminar. And then there was some trabecular here, and then it resolved by 6 months. This is again baseline separated, and you can see how it becomes hypodense. So this hyperdense area became hypodense, and then it went on to resolve. This is again a baseline laminar one, and you can see how all these membranes go away and it becomes hypodense. And then about 3 months later, it is resolved. This is again a gradation one, and you can see about 6 months later, it is resolved. But you can see that there's still a faint layer of membranes right at the periphery here. And then what about loculated or trabeculated hematomas? See, this is a loculated one. But these also resolve very nicely with MMA embolization. This is again a trabecular one with hemorrhage. And again, this is the final picture, completely resolved. You can see how this patient has some midline shift, but we have opted to just treat it with MMA embolization. This is again a patient with trabecular chronic subdural hematoma and treated with embolization. So the one thing we have noticed is that immediately after embolization, in the first few days, there is increased density. And this is because the membranes have a lot of vascularity and the contrast material diffuses into the membranes. And because it's been embolized, it tends to stagnate there. You should not reinterpret it. You should not misinterpret it as rebleeding. So this is an example. So this is a hypodense hematoma. And you can see after the procedure, there are some hyperdense changes. And if you measure with Hounsfield unit, you can see that the Hounsfield unit goes up the first day post-op. But by 8 days, you can see that it's come down to its previous hypodense kind of structure. And what about the volume? We have a way to analyze the volume on the images. And you can see this would be at baseline 131 centimeters cubed chronic subdural hematoma, 2 days post-procedure, 9 days, 23 days, and at 48 days. You can see, so by 48 days, it is at least half the size. And then by 5 months, it was completely gone. So this seems to be the progression in terms of the hematoma resorption. There are multiple trials going on, many with tranexamic acid, some with decadron, and but there are also trials now with mid-meningeal artery embolization, mainly with liquid embolic agents. We ourselves are trying to do an NIH trial with Peter Khan and Farhan Siddiq. Hopefully it will get funded. The other thing I wanted to tell you was, we talked about the time duration. It takes, 45 days for the midline shift to get better. and for 2 to 3 months for the subdural hematoma to completely resolve. But despite that, after the embolization, the first few days, the patient feels better. And I'm not sure why this is, but this is the other thing we also see, which has been reported by the Barrow group, that their headaches get better. One of the symptoms of chronic subdural hematoma is a headache. And it may be because the dura is a pain-sensitive agent, pain-sensitive structure, and by embolizing it, we are managing the headache also. So they symptomatically feel better, and even their neurologic deficits get better. And the CT scan findings actually lag the clinical recovery. So this is a series that analyzed. They found that the chronic headaches that the patient had before the subdural hematoma also got better after the embolization. So what are some unanswered questions? We still don't know the natural history. See, what's happening now is, I would say thousands of patients are receiving middle meningeal artery embolization. It's kind of interesting how the adoption has increased so quickly. And I'm not sure that all of them need to be embolized because, we would monitor some of these patients in the past and they would just resolve by themselves. So we need trials where we can randomize these patients to treatment and observation. And I think that's one of the things that we want to do. The best method of embolization is are particles safe, or is it liquid embolic safer? Does just putting a coil in the main trunk, is that adequate? Safety in the elderly, because many of these patients are elderly. From what we can see, it appears to be a fairly safe procedure, but we need data which is rigorous, which has been rigorously analyzed. And then the question is, for a patient who is a little symptomatic, can you do MMA embolization and steroids, and do they get better quicker? So it's an interesting modality of treatment, and I'm going to close with this famous saying by William Osler: "To wrest from nature the secrets which have perplexed philosophers of all ages, to track to their sources the causes of disease, to correlate the vast stores of knowledge that they may be quickly available for the prevention and cure of disease. These are our ambitions." And I think this is very true for MMA embolization. Chronic subdural hematomas we've always known about them, but it's only recently we have understood the cause and how we can prevent and cure this, especially in the elderly patient. So thank you very much again for giving me this opportunity. It's been a pleasure.
Thank you to all our participants. Please remember that due to a last-minute occurrence, Dr. Thomas was not able to do the lecture live, so we had to use a pre-recorded backup. So please send your questions on the Q&A panel with your email attached, so then we can send the questions to Dr. Thomas, and then we can send them back to you. Thank you all for having part of this lecture. And we now are going to continue with the next talk, which is Dr. Christopher Ogilvy's lecture about unruptured aneurysms, who to treat. The link will be available in the chat section. And thank you all.